Okay, thank you very much. Maybe just, that's it. Can you see that then? So, thank you for coming again. Oh, I need this thing. So this is something that I've been thinking about, and it's probably the most, in my university, it's the most one of the most controversial things I talk about. In fact, I talked about it once in a lecture, and then I wasn't ever allowed to say it again. The students liked it, but the staff hated it. Right. So, and they wouldn't let me give it again. So now I only give it where I get the chance. So everybody will have heard of the Global Burden of Disease project. This lecture is based about a paper that I wrote about it. And basically what I was trying to say, I tried to put it very nicely in the paper. But the main part of the argument is that it's a complete waste of time. And the world would have been better off had it never been done. That's basically the argument. But I want to go through the steps of that argument. So, the big idea with the Global Burden of Disease study is that if we could add up all of the suffering in the world, if we could sort of get a measure of, if we could count all of the ill health in the world, then that would help decision makers, researchers, and citizens understand what the most important problems are, right? And then you could compare health across communities and over time, and you could guide assessment of where health information systems are weak by identifying data sources required for burden calculation that are missing. So basically that one is just, these are the two reasons, and that's another one, but that one's only valid if these two are worthwhile. Because that's saying, right, okay, if we could work out disease burden, we could find out where we need information to work out disease burden that we don't have. So it's basically helping decision makers, researchers, and citizens understand what the most important problems are. But what does that mean? Most important. What does most important mean? I mean, what's the most important health problem in the world? Do you think? What would you think the most important health problem is, and why? Sorry to pick on you. You just had a nice bright pink pencil case that attracted my attention, and she hides it under the table.
This is not pencil case. This is
Glasses case. Oh well, it's even better then.
I guess it's infectious disease.
Why do you think infectious disease are the most important problem? It's curable. All right, that's interesting. What about you? What do you think is the most important problem?
Heart disease.
Heart disease. Why do you think that's the most important problem?
The most frequent.
It's the most frequent. Okay. Well, I think the thing is, I think this is a bit vague. What most important is it's a little bit vague. This is what important people in leading global health positions say about the Global Burden of Disease study and why they think it's important. So the Director General of the WHO says, accurate assessment of the global, regional and country health situation and trends is critical for evidence-based decision making. Okay. Which is interesting because we've been doing public health for a long time before we had it. But now it's become critical. The editor of The Lancet said, an important contributor to our understanding of present and future health priorities. Right? It's saying what the most important are. These are our priorities. So that, if we add up all of burden of disease in the world, cardiovascular disease might be the number one. So that's where we should be putting our efforts. That's our priority, cardiovascular disease, because it's the most frequent health problem. And the Global Burden of Disease study challenges us to be rigorous and clear in our arguments about the criteria that should be used to guide programming investment decisions. That's the president of the World Bank. So the president of the World Bank thinks we should decide where our money goes on the basis of global burden of disease calculations. Now that's a really big worry, I think. There's one person, the global burden, this is Richard Horton writing in The Lancet, the global burden of disease has recently been called by one professor of epidemiology a public health disaster. And that professor of epidemiology is me. Right? So I'm one of the few people who think that it's all a complete waste of time, right? And so and that's my job is to convince you that it's a waste of time, or to be convinced by you that it's not a waste of time. Either of those is good. So this is what you see a lot of in global burden of disease study calculations. It's like sort of when I was a kid, my favorite television program was Top of the Pops, right? It was like a music show, and everything was coming up, and this particular band was now number 1, and someone else was number 3, and this is like Top of the Pops of disease, right? So ischemic heart disease, you were right. Ischemic heart disease is number 1, right? HIV is number 5, but HIV is going down. No, HIV is going up. Low back pain is going up. Malaria is staying where it is. Different problems. I did a lot of work on injury control, and I remember saying to I remember Etienne Krug at the WHO Health Organization, and I said, how's it all working out with this global burden of disease study and injury? And it says, it's quite good. And I said, what do you mean it's quite good? He said, injury's gone up. What? How can anybody say that? It's quite good because injury's gone up. And it was good because the funding they get for their little empires is related to disease burden. People who are interested in mental health are really excited because mental health is really going to the number 1, by something like by 2020 or something like that. Mental health will be number 2 or number 1. Depression is the most important health problem in the world, and perhaps we should spend all our money on it. So these things going up and down, I think it's all very strange, and I don't think this is a very when you have people who work in the WHO who are saying things like it's good, injury is good because we're going up, I think we've got a problem, and it really works its way. People go, right, what's the most common problem in the world? Oh, that's the problem we should be spending more money on. So this is Richard Horton writing in The Lancet again. He's saying in 2010, the total amount of funding in the world for health was 28 billion. Given that non-communicable diseases account for 2/3 of it, how much of that money do you think is dedicated to these diseases? Only 5%, right? So, if he's thinking cardiovascular disease and chronic disease, 2/3 of the burden, they should get 2/3 of the money. And if it's not, there's something wrong. And you get after the global burden of disease study, you get lots of different papers calling, it's like sort of burden envy. It's like the mental health people said, there's no health without mental health. Our problem is the biggest problem in the world. And then, the maternal and child undernutrition people said, no, this is the biggest problem in the world. And then the chronic disease people say, we've got the biggest problem in the world. And that's what universities and schools of public health are like. You've got these little you've got, it's like these little kingdoms built around diseases, right? And everybody's fighting to have the biggest disease burden, you know, and it's very strange. So I want to make some counter arguments to this. And there are three arguments, and I think they're all reasonably strong, but I could be wrong, and I want you to tell me if they're not. And first of all, there is no such thing as disease. Disease is not a thing, it's a concept. And you can't count it in the same way as, you know, disease, we think it's a real thing, but it's not. It's much more difficult. It's a concept. So I think there's no such thing as disease, and even if there was, its burden couldn't be counted. And even if it could, it would not be a useful way of setting health priorities, right? So I think there's three arguments there. First, there's no such thing as disease. Second, you can't count its burden. It's impossible. And third, even if you could, it wouldn't be a worthwhile thing to do. So there's no such thing as disease. So there was a guy, Geoffrey Rose, worked in the London School of Hygiene and Tropical Medicine, and he said a few things about this some time ago. You know, he had a paper called The Trouble with Disease. And he said, well, the trouble with disease is there's no disease that you either have or you don't have, except perhaps sudden death and rabies. All other diseases you either have a little or a lot, right? So, like, disease isn't a sort of, disease is like a pathophysiological process, and you can have more of it or less of it, but a lot of people don't either have it or not have it. You know, we all have it. We might have a little bit of it, you know. Most people my age have a little bit of cardiovascular disease. We might have a little bit of, I don't know, low mood or something like that. But so disease isn't there or not. You have a little bit of it or more of it. Now, the counter argument, people always cite death. They say, well, death, you're either dead or you're not. Well, even then, you get patients who are brain dead. So parts of them are alive, but their brain is dead. But the one that everybody cites to me is pregnancy. Well, you're either pregnant or you're not. And they say, well, that's surely dichotomous, right? You're either pregnant or you're not. And then I tell them about my wife, who once told me that she was very pregnant. And so I said, don't be ridiculous, darling. You're either pregnant or you're not. It's completely dichotomous. But my wife's always right. So it was twins. So she was very pregnant. And so there she is celebrating. I was right. I was very pregnant after all. You were wrong. So, and she could have been even more pregnant, and I was pleased that she wasn't. So let's take something like myocardial infarction, right? So that's, a myocardial infarction is either there or not, surely. You've had a heart attack, Mr. Jones. You have not had a heart attack. So heart attack is either present or absent. Well, that's not necessarily true. And so in order to work out how to define a myocardial infarction, they have to every now and then, they get all of these experts from all around the world to sit around a table for quite some time and figure out what a myocardial infarction is. And it's much more difficult than it seems. So, this is the third universal definition of myocardial infarction. And any necrosis, so basically you've got a heart and you've got heart muscles, and if heart muscle cells die, that's called, heart muscle myocardial ischemia. So any necrosis in the setting of myocardial ischemia should be labeled as an MI. So if you get any death of myocardial cells because they're not getting enough oxygen, we should call that an MI. But that's very tricky because as tests of myocardial necrosis have got more sensitive, more and more people can be defined as having a myocardial infarction. And so they recognize this as a problem. The development of more sensitive markers of myocardial necrosis mandates further revision. So the advent of this troponin testing dramatically increased the numbers of myocardial infarctions. So myocardial infarctions are going up because we're better at detecting myocardial ischemia. And actually, the concept of it as a dichotomous thing that's either present or absent is getting more difficult to sustain. So these are patients who have undergone surgery. So if you have, patients who are having operations for various things, if you measure their troponin in their blood, if this measure of myocardial ischemia, so troponin is this protein that's released by myocardial cells when they die. And, some people, there's a whole range of troponin concentrations in the blood. Some patients have a higher level, some people. So where you say, well, look, you've had a myocardial infarction, you haven't, it's totally arbitrary, right? So where you decide when people have had a myocardial. So a myocardial infarction isn't a thing that exists. It's just an idea that we define, right? So it's very easy for me to count the chairs in the room because these chairs they're a discrete thing. You can count them, but counting myocardial infarctions is much more difficult because a myocardial infarction is just what you say it is. And if you make the cut point here, there'll be fewer. If you make the cut point here, there'll be more. And the risk of death is linearly related to your troponin release. So, these people have a worse prognosis than these people have a worse prognosis than these people, and these worse than these. So a myocardial infarction is just what you say it is, and it's nothing more. So I don't think there is such a thing as a myocardial infarction. It's just what we call it to be. And this is the relationship between fasting glucose and stroke, ischemic heart disease, cardiovascular death. See, it's a continuous relationship, yeah? So glucose, if your glucose passes a certain threshold, if your fasting blood glucose is greater than 6.9 millimoles per liter, we say that you've got diabetes, yeah? We say that you've got non-insulin dependent diabetes if your fasting blood glucose is higher than 6.9. Now, if we made it higher than 6, there'll be a huge increase in the global burden of diabetes. Enormous increase in the global burden of diabetes, just because what we've called diabetes has changed slightly. So, and there's no reason why it shouldn't be 6, because having it 6 there's a worse prognosis if it's 6 than if it's 5. So if we said diabetes is having a fasting glucose greater than 6, there'll be maybe diabetes would go right up to the top of the charts in the global burden of disease charts. And so there's no such thing as diabetes, it's just what you call it. There's no such thing as, this is blood pressure lowering. So, blood pressure lowering according to baseline blood pressure. And the lower your blood pressure, the better. Whatever your blood pressure is, the lower your blood pressure, the better. So, if your systolic is greater than 160, if you lower it, there's a reduced risk of death. If your systolic is less than 140, if you lower it, there's the same reduced risk of death. There's no such thing as hypertension. Hypertension is not a disease. It's just what you call it. Same with hypercholesterolemia. Whatever your blood cholesterol, the lower the better. I went to my GP. When I was 50, I went to the GP. I thought, well, 50? My baseline risk of cardiovascular disease is going up. I should take a statin. And so I went to the GP and I said, I want to take a statin. And she said, well, let me measure your cholesterol. And I said, no, 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 I don't want you to measure my cholesterol. I just want you to give me a statin. And she found, oh, that's very difficult. And I said, well, why do you want to measure my cholesterol? You know, I'm not interested in my cholesterol. I'm just trying to lower my cardiovascular risk, and just give me a statin, you know. She found it very difficult. She wanted to diagnose hypercholesterolemia. She wouldn't let me have a statin. I had to take up papers from the Lancet showing that whatever my cholesterol is, it doesn't make any difference. It's better if it's lower, you know. So people in China have a much lower cholesterol than people in England. You know, whatever your cholesterol is, the lower the better. But this disease concept's getting in the way, you see. You know, so doctors don't realize this. They won't let you have a statin or unless you've got hypercholesterolemia, which is there's no such thing as hypercholesterolemia. It doesn't exist. There's no such thing as obesity. You know, obesity is another made-up disease. You know, there's a population distribution of body mass index, and if you decide to cut it at 30 milligrams per kilogram, or 30 kilograms, what is it? Kilograms per meter squared, isn't it? Kilograms per meter, it's completely arbitrary. You know, so there's no such thing as obesity. So I'm not saying that there isn't suffering. There are causes of disease and there are effects, but diseases are concepts, right? They're only what you define them to be. And so you can't count them like you can count chairs, you know. And these things are very fluid. And so this guy, Carl Wunderlich, he spoke about this a long time ago. He said, a view which takes abstract concepts as things, implying their actual existence, and treating them as entities is a logical blunder that has frequently crept into medicine and flourishes there. So doctors are so used to talking about this thing, diabetes, and you know, they talk about diabetes, you know, what do you do? I work in diabetes, and then they come to believe it's a real thing, you know, and you can count it. You know, how many diabetes are there? Well, let's count them. But so I don't really think there's any such thing as disease. It's only what you define it to be, and you know, you could greatly change the global burden of depression depending on how you define depression. You know, I mean, I find the diagnosis of depression. You know, I looked it up this morning. ICD-10. You know, a bit complicated. You know. 4 of these things for at least 2 weeks, and there's a list of different things, and it's very confusing. So I first of all, I don't think there's any such thing as disease. Next thing, if there was, its burden couldn't be measured. And the reason why you can't measure the burden is that the disease, you can have one death. Everybody gets one death each, yeah? But you can't say what caused it. It doesn't have one cause. So you can have arthritis, and you can have arthritis and heart disease and depression, and you can die. And so the problem with the burden people is that they've got to attribute that death to one of these diseases, you know. So was that death due to the depression, or was it due to the arthritis, or was it due to the heart disease? You know, everybody in epidemiology knows that disease is multifactorial, right? That there's no, you know, disease doesn't have a single cause. Well, and death don't have a single cause either, you know. You can actually die. You can die of one thing or another, or the combination of 2 things, or the combination of 10 things. So it's very difficult to say what death is due to what disease, because you can have many diseases at the same time. So you can't calculate the burden of disease because the diseases aren't mutually exclusive. And if you look at the global burden of disease study, if you go to the methods section and try and figure out how they did this how they made these judgments, it gets very confusing. And it gets you read the methods section and it gets more and more confusing, and because it's all trickery, because conceptually it's wrong. It can't be done, right? You can't attribute this disease to one cause. I mean, doctors do it on death certificates, but it's not scientific by any stretch of the imagination. We wouldn't do that in epidemiology. So all of this sort of, so diabetes, like it's going up to number 14, but you can have diabetes and iron deficiency anemia and tuberculosis all at the same time. And if you die you can have all of those three things and die, and then someone has to decide which one of those things you died of. They're not talking about the interaction of these things. So, first, there's no such thing as disease. Second, if there was, its burden couldn't really be counted because all of these things are not mutually exclusive. And then the third thing, I think, is the real killer, that even if you could, it wouldn't be worth doing. So the idea of, burden of disease is like the volume of human suffering, right? So these are two diseases. You can tell that I go to the 7-Eleven late at night. But last night was yogurt and jelly. So this is bigger than this, yeah? So these are, imagine that the volume of this is a measure. This is disease A, and it's got this volume, right? This is the amount of human suffering, disease A. This is disease B. Now, I think, you can see that this has a bigger burden than this, yeah? Now, if you could eradicate a disease, A or B, which one would you eradicate? If you had a choice, you can eliminate one of these diseases from the face of the earth, which one would you eliminate? We've taken into account human suffering in the disease burden. We've taken into account the numbers of deaths, the number of life lived with disability. They've measured them on the same metric, right? So we're measuring suffering on the same scale. A, B, which one would you eliminate? A. Get rid of A. Yeah, let's eliminate disease A. That's the obvious thing to do. Yeah, we would definitely eliminate the problem with the biggest burden, and that's very good. The only thing is, I don't believe we eliminate disease anymore. How many diseases can you think of that we've totally eliminated? I can think of a few. You must be able to think of a few, your public health students. Smallpox, yeah. So we eliminated smallpox. Polio, maybe. Polio's on the edge, might eliminate polio. But what about, do you think we'll eliminate heart disease? We've tried for quite a while. Do you think we'll eliminate depression? Or what else? I don't know. So it's very unusual to eliminate disease, I think, So if these measure the burden of suffering, I don't think we're going to eliminate things. But what we do is we can try and reduce the amount of human suffering from diseases the best we can. And if we do that, then it's not about the size of the disease. It's about the effectiveness of the interventions, yeah? So, like, these are intervention. So imagine these are full of liquid. You know, like this is an intervention for this disease, and this is an intervention for this disease. Now, this one is the bigger, and you see you can scoop out all of that suffering with this because it's a more effective intervention. Yeah? This is a less effective intervention. So the bigger problem, there's a less effective intervention. The smaller problem, there's a more effective intervention. So how much, now which is the most important problem? Because I can get rid of all of this just with one intervention. And this, you know, it would take me much longer to get rid of that one. You know? So it's not the size of the disease that matters. I mean, it's, normally I do this with a bucket. I have a big bucket for one disease and a smaller pot for another disease, and then I can scoop them out. But these are the biggest things I could find in the 7-Eleven. So, you know, you can see that, this intervention, less effective. So there's less gain in health from tackling this problem than you have with tackling this problem. So the size of the disease is completely irrelevant. The most important problem is the problem you can do something about. Yeah? So, if we go back to our disease charts, ischemic heart disease, number 1. Our measles, number 56, right? Now, if with a million, if we've got, like a certain amount of resource, and we can get rid of measles really easily, we can vaccinate against it. We've got £1 million, we've got £1 million to spend. With £1 million, we can vaccinate everybody and get rid of measles. With £1 million in ischemic heart disease, we can do very little, say, if that was the case. Then what's the most important problem? The most important problem is measles. It's not ischemic heart disease. So the most important problem is the problem that we can do something about. So this idea that the most important problem is the one with the biggest burden is it's a big mistake that will cause, and I think maybe has already caused, a lot of unnecessary suffering. Because it means we're not solving the most solvable problems with the resources that we've got available. When you've got so much so what becomes really important is the cost effectiveness of intervention, right? It's show me an intervention that's effective, and then let's have a look at how cost effective it is. And if resources are limited, then you should put the best thing, the most important problem is the problem for which you've got the most cost effective intervention. So we should this is a sort of hypothetical cost effectiveness analysis. So this, we've got some different programs, different things we can do. This is the cost per QALY gained, right? So the incremental cost per QALY, the incremental cost per patient compared with alternatives. If you have £1 million, you should invest it in the most cost-effective intervention first. So the incremental cost per QALY is lowest for this intervention, isn't it? So we should put most of our money here first. And then, when we've completely dealt with that problem, then if we've got any money left over, we should go for the next cost-effective one, maybe this one. And that's how we should be allocating resources. We should be allocating resources in a rational way and not on the basis of this burden thing. This burden thing is just and mischievous nonsense that schools of public health love because basically academics just compete with each other to say my problem is more important than yours. We have a series of lectures in the London School of Hygiene, and they're called Global Public Health Lectures, right? So they're Global Public Health Lectures, and they invite different professors to come along and talk about their problem. And they always say the same thing, you know. They say, malaria is a huge problem, it's getting worse, my problem is the biggest problem in the world. And then someone next day there's somebody who's interested in obesity, and they say, obesity is shooting up, we're all going to be obese in 100 years' time, obesity is going to be number one. And then the mental health people say, my problem is bigger than you. It's ridiculous that actually people in public health are competing with each other about how big their problems are. I just think it's like childish, you know? Why, like I've worked on trauma and injury, but why would I want to promote something for trauma if, using that same amount of resource, we could save more lives treating malaria? For example, insecticide-treated bed nets are one of the most cost-effective interventions in the world, I think. It's probably one of the best buys in public health, right? So if you were talking to the Prime Minister of Malawi and said, right, okay, how much money have you got to spend on health this year? You know, what should we spend it on? You know, well, where can we get the most benefit? You know, insecticide-treated bed nets, and you know, let's do that. Let's do that first. I mean, why wouldn't anybody in public health say that? You know, just because they worked in the area of cardiovascular disease, they should still want the best for people of the world, shouldn't they? You wouldn't want to sacrifice. You wouldn't want to cause unnecessary suffering just to sort of make your problem sound more important. That's what I believe, anyway. So, summary measures of health can help decision makers, researchers, and citizens understand what the most important problems are. I don't think that's true. I think that's a big mistake. Global burden of disease estimates do not help us decide what the most important problems are. The most important problems are the problems that we have the most cost-effective interventions for. Now, people sometimes say, well, okay, maybe it's not good for allocating, deciding what the public health priorities are, but it's better at deciding what the research priorities are. Maybe. But I'm not completely sure about that, you see, because I think research is similar in actually we should invest in the most cost-effective research. And we should be thinking, all right, what's the information yield from this research? How much does this research cost? And comparing the information yield with the cost and funding first the most cost-effective research. In terms of comparing health of communities over time, I just don't think I mean, this doesn't work for obvious epidemiological reasons. You know, like things go up and down for all sorts of different reasons. This is the age-standardized mortality in Russia by region, and there was a big peak and jump in mortality in Russia when economic situations. So it doesn't really tell you about the performance of health systems or anything like that. The things that make disease go up and down in populations are often they're macroeconomic things. It's not about provision of health resources. And if you want to monitor the performance of health systems and make sure health systems are accountable, that health systems are doing the right thing, there are much better ways of doing it. So first of all, you use rigorous epidemiological methods to establish the cause-effect associations, So if it's a disease, a cause of disease, say smoking. So smoking causes lung cancer and loads of other diseases. So you find out the link between the exposure and the outcome by using good research designs. And then you you monitor smoking, you know. You stop monitoring you forget then about lung cancer. You don't have to count lung cancer, you just have to count smoking. And you try and reduce the cause, or, you know, you reduce, and then, yeah. And then this is for another example from my own research. So like we found in the CRASH 2 trial that this drug, very cheap drug, tranexamic acid, reduces the risk of death due to bleeding in trauma patients. And we did cost-effective analyses that shows it's highly cost-effective. It's not more cost-effective than insecticide-treated bed nets. So we've done the calculation. Insecticide-treated bed nets are a better buy than tranexamic acid for trauma. Tranexamic acid for trauma is very close behind, but if there was only so much money to go around, you know, you should say, look, actually don't spend it on this. You know, I know this is my particular interest, but that doesn't matter. Don't spend it on this. Spend it on insecticide-treated bed nets, because you'll save more lives with the same amount of money. But once you've found in a randomized trial that this treatment works, then you don't have to measure trauma death rates. You just measure which hospitals have a policy of giving it. And so, you know, these are hospitals with a policy of giving tranexamic acid. So all different countries of the world. So, and a hospital there are some hospitals in the UK that don't give it. Now, whatever their mortality rates, they would be better if they used it. So you can forget about, you know, you don't have to know you don't monitor their burden or their mortality rates or anything. You forget about that. You just monitor whether they're doing the things that they should do based on epidemiological evidence. You know, this treatment works. Are you giving it? Yes or no. If you're not, then whatever your death rates are, they would be better if you did it. So you're not a high-performing hospital. And that way, you sort of remove stigma. You know, that means, so like, you know, I find this with, I don't know, hospitals, people from the, you know, people might say, you know, my hospital is the best hospital in the world. It's got all of these machines and fancy gadgets and, you know, very high tech. And you say, well, look, just come up with a list of effective interventions and ask them, are they doing it? What proportion of their patients receive these interventions? And then you can really tell if they're a good hospital or not. But when you see all of these, you know, the technology and everything doesn't mean anything. You know, are they doing the interventions that have shown to be effective and cost-effective in randomized trials? If they're doing them and all of their patients are receiving them 100% as close as possible, then they're a good quality hospital, whatever their death rates are. If they're not, they're not. So the global burden of disease study, I think, is sort of led to a sort of epidemic of, it's a kind of academic folly, and it sort of, I see it in my university a lot. It's like say this is this is a leader in mental health, right? So he says, and these are people over here. These are his followers. These may be people suffering from depression, right? And you know they say, look, this problem, your problem, is a really big problem, and I'm your leader. You know, I will lead you to salvation. Follow me, right? And they get huge followings, you know, and they become very famous, not for doing anything useful, for just declaring that their problem is big. And you know, lots of people there are many more people in my university who declare problems than who solve problems. Because, you can get if you want to get famous very quickly, declare something's a big problem. Because there'll be lots of supporters out there who'll want to get behind you and say, yeah, that's a big problem, And the journals love it. There's every week in the Lancet, there's some special series saying some new problem is the most important problem. And every day, there's a Lancet Commission on stillbirth and Lancet Commission on, rare neurological diseases. They love to declare emergencies. But I think, if you get a lot of people around you in your little army of saying your problem's a huge problem and I'm your leader, unless you can do something for them, I don't think, you're not helping them. And so I think there's ways to spot honest advocates, and there's ways to spot people who are trying to make their empire bigger. So honest advocates tend to want to remove the causes of disease. They want to implement effective interventions, and they try to use the available resources better, right? So, we shouldn't really advocate for our own diseases because we're all in global health, We should want the best for the world, I want to reduce, to the greatest extent possible, I want to reduce the amount of suffering. And the best way I can do that is by identifying the most cost-effective interventions and wanting them to be implemented. And the focus is on the purpose and not the person. Lots of people can get very famous advocating their particular problem. And, you have to be in it for the long run. This is Ian Gilmore. He used to be the president of the Royal College of Physicians. I thought he was very good. He's a gastroenterologist, and he didn't say, I want more money for gastroenterology. He worked on liver disease. I don't want more money for liver disease. He identified that alcohol abuse was a big problem. So he was not focusing on the disease, but you're focusing on the risk factor, on the cause of the disease. And recognize that alcohol is a risk factor, not just for his disease, but for lots and lots of diseases. So, it's a risk factor for high blood pressure, stroke, heart disease, pancreatitis, liver disease, liver cancer, cancer of the mouth, breast cancer, bowel cancer, depression, dementia, impotence, infertility, road trauma, violence, divorce, domestic, lots of things, right? So if you want to do something about disease, well, it's very obvious, then you focus on the causes. And some causes are more important than others because they have bigger population attributable risks. Yeah? Do you remember population attributable risks from epidemiology? So some causes are very important. Smoking, alcohol, physical inactivity. And so you focus on the cause, but not, he didn't say, we want more money for liver disease. He was trying, and then you try and make policy change, and it's very difficult. The way I got this sense of the danger of disease burden when I was in Nigeria, and we were doing this. This is the CRASH 2 trial. And this is the woman trial. This is the trial of tranexamic acid for postpartum hemorrhage. And there was a hospital in Nigeria who was recruiting very well into the woman trial, and then all of a sudden it stopped. So we thought, wow, that hospital in Nigeria was recruiting really well. These are the doctors at that hospital. that hospital was recruiting really well, and they were one of our main recruiters, and they stopped recruiting. Let's go and find out what's happened. So, when we were in Nigeria, we went to this hospital, and the doctors took us to the hospital, and it was very easy to see why they weren't recruiting, because the hospital had closed. And the hospital closed because there was no money for the doctors. Right? So the doctors stopped getting paid by the government, and so the hospital had to close. So, so we're walking around this hospital, and this hospital served a very poor community of a lot of people, and it just, the gates closed. And I was in the hospital, we were checking the records of the patients who'd been recruited, and I saw a light on, and I said, it's not completely closed. There's somebody working in this hospital. Well, that's good. What are they doing over there? And they said, that's HIV. Yeah. And so that bit of the hospital did not close because it's funded by the US. And it was basically, they had this initiative where it was a maternity hospital. If you were pregnant and HIV positive, you could get antiretrovirals. So we had this situation where this maternity hospital was closed, but there was one piece of this hospital that you could get in with. So if you'd had your baby and you were bleeding to death, the hospital would be closed and you'd die. If you had an obstructed labor, the hospital is closed. You have to do what you can. You could easily die. But if you were pregnant and HIV positive, you could come into the hospital and get antiretrovirals. I just thought, my goodness, this way of thinking about diseases is really strange if we can get a situation that's so strange as that, And then why do you get that situation? Because, in the politics of public health, some people are saying, right, I'm the king of AIDS. I'm the king of HIV. And I'm going to bring HIV treatment to all of the world, right? Because they say, I'm the leader, you're all the sufferers, follow me and I'll bring you treatments. And I'll get you money. And they lobby government to get money for HIV only. And then you can get ridiculous situations like closed maternity hospital and one clinic. And there was a soldier with a security guard with a gun, and you have to come, and if you're in labour and dying, he turned you away. But if you had HIV, he would let you through the door. I just thought, wow, that's really weird. I don't want to have anything to do with that. So that's it, really. That's my case against the Global Burden of Disease study. It's very popular. It's very popular with the Lancet. You can get very high impact factor publications. I saw there's a professor in Tokyo, Professor Shibuya, published an analysis of the burden of disease in Japan. I'm not sure how much it's going to help Japan. Perhaps you can. Perhaps it will help. Perhaps it won't. I think it's more likely not to help than to help. And if it doesn't help, you ask yourself, well, what use was it? What's the point of it? I don't know. Anyway, that's enough. I'd like to hear what you think now.